I started working with highly suicidal people. As it turned out, the people met criteria for borderline personality disorder, but A, I had never heard of borderline personality disorder, and B, I didn't know what it was. Even if you told me the name, I wouldn't have known. So that was the beginning of the whole thing. I had no idea what I was doing, except that I was studying suicide. What happened was standard behavior therapy of the 1970s and early 1980 blew up. And the main reason it did is because what it requires for it to work is for a person to come in and you be able to say, okay, here's the problem and here's what we'll do to change it. And for the person to say, okay, I'll try that. But the people I was dealing with immediately said, you're saying I'm the problem. And so they were so sensitive to any invalidation or statement that they were the problem that the treatment blew up. And they would either get angry at me, hide behind a chair, storm out, quit therapy, yell and scream, cry, or say they're going to kill themselves. So it didn't take me too long to figure out this was not going to work out. So I thought, okay, we're going to switch to a more acceptance-based treatment. So I'm going to validate and be very accepting. So I tried that. That blew up also, because then the patient said, you mean you're not going to help me? You're just going to listen to me? Most of the patients I treat have already been through a whole lot of therapy where you talk, get listened to, and understood. The problem is talking, being listened to, and being understood doesn't necessarily make anything change. So then they got really upset with me because I wasn't helping them change. So that's when I realized that I had to pull together a major emphasis on change with a technology of acceptance. So I had a technology of change, now I needed a technology of acceptance. The technology of acceptance primarily was validation. So it's behavior therapy with a huge amount of validation. So problem solving, validation are the core components of the treatment. In our current research, we are finding that the skills that are taught in dialectical behavior therapy may be the most critical parts of the entire treatment. The skills that we teach are in 4 groups. So the first group is mindfulness skills. DBT was actually the first psychotherapy that put mindfulness into psychotherapy. We did not put meditation into it because most of our clients really could not tolerate focusing on their breath and doing meditation. So what I did was, for mindfulness skills, what I did was to translate Zen mindfulness practice into behavioral language. I said to myself, what were my teachers really teaching me to do? And then I packaged those and taught them to the patients. That's mindfulness. Those are the core skills, and every other skill depends on those skills. So they're the first ones everybody gets. The first skill is observing. So it's just learning the skill of noticing, paying attention, noticing what's in front of you. noticing what's within you, noticing what's in your mind, noticing what's in your body, and noticing what's outside. That's the skill of observing. That's central to all contemplative practices. Second one is describing, where you describe what you observe. The basic idea is you can't describe what you didn't observe, meaning you cannot describe what's in someone else's mind, among other things. And the third one is participating. This really comes straight from Zen. It's the skill of becoming one with. It's a skill of throwing yourself in, letting go. So it's going with the flow, so to speak. So that's what you do. Then the question is, how do you do it? So the way you do it first is non-judgmentally. Non-judgmentally means neither good nor bad. It means not judging. The second is in the moment. It's paying attention to just this one moment. Primarily because that's all that exists. It's my favorite skill at the moment because I love thinking about the idea that nothing exists but this one moment. The third is effectively. That comes straight out of Zen. And effectively means doing what works and giving up having to be right all the time. So it's instead of being right, being effective. It turned out, without my knowledge, the people I was treating had 4 or 5 other psychological disorders. So they had major depression, eating disorder, post-traumatic stress disorder, anxiety disorders, all sorts of other disorders. So it turned out that if I wanted to work on one problem, you had to be able to put another problem on the shelf, at least for a while. And that's when I discovered that the clients had no distress tolerance. At that time in history, behavior therapy was very focused on change and was not focused on distress tolerance. So I had to build a set of skills to teach the clients how to tolerate one thing while we worked on something else. And that's where distress tolerance skills came from. Borderline personality disorder is primarily a pervasive disorder of emotions. It is the inability to regulate emotions. And by emotions, I'm talking about a very broad spectrum. Not only how you feel, but the physiology of emotions, the experience of emotions, and the actions associated with emotions. It's a group of people with extraordinarily intense emotional suffering who are also simultaneously unable to change their suffering and regulate the behavior that comes from that suffering. So the problem there is, how do you teach emotional regulation? So I developed an entire module of strategies for regulating emotions. And those strategies have been taken from the science of emotions and from the evidence-based treatments that treat emotions. You know, if we had a person who had a treatment for one emotion, I simply looked at what do those therapists tell that patient to do, and then I repackaged all that as a skill. I would have to say about half of my patients, if you ask them how they feel, what their emotion is, they're functioning like they're looking in a fog. They look down and they think, I have no idea. They have no idea what their emotion is. So the first thing we have to do is teach them how to do that. And we have strategies which are very effective for that. And then we have to teach them how to regulate. So there are many strategies for regulation. You can look at the vulnerability factors. So often you're very emotional today because of something that happened yesterday, because you didn't sleep, because you didn't eat, because of some stress from yesterday. So one of the things we look at is what are the factors that make you vulnerable to being emotional, and how can you change those factors? So we look at that. We look at what is the prompting event, meaning what happened right before. Is that something that you can change? If you can, that would be teaching problem solving. If you can't change it, we go to the next, which is what's your interpretation or what's your thoughts about that. We have a skill called check the facts. How do you check the facts to see if your interpretations are correct? So on and on. I mean, there are a lot of different sub-skills in emotion regulation. We know that emotion regulation skills are effective. We've got data on just that all by itself. They are effective in teaching people how to regulate emotions. Interpersonal skills have several components. It's how to get what you want while you maintain a relationship, and how to get what you want, maintain a relationship, and keep your own self-respect. So it has those three dimensions to it. So there's three sets of skills. And how to know when to use what skill, and how to know when to ask, and how to know when to say no. So it teaches a lot about timing. We've now added on to these skills in our new version, which is how to find people and get them to like you, how to validate others, how to join conversations, how much to self-disclose or not self-disclose. So it's got all these sorts of things in them. We also have, in the interpersonal skills now, we have a set of what's called walking the middle path skills. How to validate other people, how to be dialectical, which means not going to extremes, how to see other people's point of view and your point of view at the same time. A number of skills like that are in that section. The treatment I developed, dialectical behavior therapy, or DBT for short, actually has its focus as building lives worth living. We're not a suicide prevention program. We're a life worth living program. But it's very easy to skip the life worth living and try to keep them alive, mainly because it's too scary to think they're going to die. The way I deal with it is I practice the skills I've developed, my main skill, which is radical acceptance. And I have to radically accept that they could die. I once had a patient who had tried to kill herself a lot of times. And she was young. And I was younger than I am now and less experienced than I am now, and was terrified she was going to kill herself because she kept trying and she just didn't succeed. So I told the parents, I said, okay, here are the options. We can lock her up and keep a nurse with her 24/7, which you can pay for, and I guarantee you we can probably keep her alive. Or you can let her be out of the hospital, take a chance on a life worth living, which might be a chance that she'll be dead. So we can either keep her alive or go for a life worth living. So they said, okay, a life worth living. So I said to her, all right, we're a life worth living.